computer. Yes, so what we're talking about it, the atlanto-occipital joint, which is basically a flexion extension joint predominantly, as we do it with a bit of a side bend and rotary component, depending on which literature you read. And we've been talking about if I do, let's say, when I do forward head protrusion, basically what I'm going to get is I'm going to get extension at that craniovertebral joint or the AO joint. I'm going to create extension there. Retraction is going to give me basically craniovertebral flexion. Chan was talking about doing is as a release technique, he'll take them into protrusion to see if I take them into protrusion, does it reduce their headache? Is he looking at a slackening of the posterior structures? Does he create suboccipital, maybe muscle inhibition by putting the muscle in a shortened position and then being able to take it through its length? Kind of a classic release technique of maybe taking it forward and doing that. But what we're also doing at that moment is we're mobilizing craniovertebral joint into flexion, and we're probably taking C2, C3 also into extension. I'm sorry, we're mobilizing craniovertebral joint into extension, occipital and C1. Likewise, C2, C3 would be going into an extension moment as well as it going down into the lower cervical spine. Have those motions as well occurring. And again, suboccipital muscles, then again, we've released them. So, we can think about this, and sometimes we're doing a muscle technique, other times we're doing a joint mob. So we assess this joint. It's one of the ways we're going to assess it. You can take it into protrusion to see how willing is this joint to, at that point extend. And if it is limited, then I got to determine, is it the occiput on C1, or do I have a problem maybe in C2, C3 that can't properly extend? And you're going to see a fair amount of C2, C3 arthritis. And these are the levels which tend to generate the servogenic headache. You're going to get them from these upper craniovertebral levels at a much, much higher rate than you get them from the mid-cervical spine. So your craniovertebral headaches, the ones you're seeing, typically C2, C3, and above is where they're going to come from. So let's say Chan now. He takes them back into basically what we would think about the chin tuck position. So if you come back into the chin tuck position, that Atlantic occipital joint, the occiput's going to glide posteriorly on the C1 facet joint. And this is one where we're going to find probably more restrictions in this direction. And it could be because we have myofascial tone. It could be because they've been living in a forward head position for so long. There's a bit of capsular fibrosis and changes that go on. So I get a fibrotic end feel. It could be because I have an articular restriction because this joint has been stuck into a craniovertebral flexion for so long. It's lost its ability to posteriorly glide on one side or another. And you will find these in some of those patients with the suboccipital headaches. And you're looking for this because this will be very low-hanging fruit. And then in some of these people, we need to mobilize this joint. And you'll probably maybe get into manipulations. We'll definitely get into mobilizations of the joint. And we can talk about, the muscle release techniques. Because sometimes when Chan's doing that muscle release technique, he may be correcting a joint glide. And we were thinking muscles, so we think, oh man, I got the muscles to relax and I got it to reset. When actually by working them into protrusion and retraction and extending and flexing this occiput and C1 joint, maybe we're restoring the posteriorly glide of C1 on the right-hand side. And what that's going to do, it's going to down ramp some of the suboccipital tone, and it's going to decrease some of the driver of what may be causing that suboccipital headache. So that's why even like what Chan's doing, it's not saying that, okay, Chan is wrong. Chan is probably right in many cases, but some of the time he's probably being able to, by moving them back and forth within these ranges, improving some of that craniovertebral flexion. And this is important kind of coming from both directions because, we've all been taught, oh, we got to do chin tucks, deep neck flexors, they're underactive, my sternocleidomastoid and my splenius capitis and these other muscles are hyperactive with this forward head posture, and they do it. And it is, yes, that is one of the classic things they see. But probably what we're also getting a bit of too is if I have an articular restriction holding me in craniovertebral extension in that forward head posture, whether I have, let's say, the occiput C1 joint in craniovertebral extension, or I'm extended or stuck in extension at C2, C3, then that chin tuck and that posterior glide may not be sufficient to correct the articular driver. And that's kind of where, we'll be spending our time in the lab session. We're going to go over all of it, but playing off the what they found in the muscular research with how the articular movement patterns will dictate what they do. So those people get better fast, probably will maybe addressing more of an articular restriction. And Gwendolyn Jall, who published a very nice book on neck pain, like a research summary of it, which is very good, because that's one of the things they'll get into. And she laments that in some of her podcasts that, when you manipulate the cervical spine, you can eliminate pain pretty quickly when it's a joint dysfunction. So the results with mobilization or manipulation can be really immediate, reduce pain. But what they find sometimes is that if you see the muscle balance restore between the deep neck flexors and some of the muscle groups, it doesn't restore or it may be short-lived as this person falls back into their muscular pattern. So they're going to be back generally in 6 months, 8 months at some other point because that muscular hypertonicity and inhibition wasn't maybe fully addressed or rehabbed. So it's a point we'll spend some time with discussing during the weekend as well, is that I can get people and fix their necks pretty quickly if it's an articular restriction and you look like a rock star doing it. But then and the hard work is when they have less pain, is how do I get them to commit to basically working on some of these endurance patterns if it's an endurance issue, or a motor movement control issue if they're moving all ratchety in their neck, they can't control smooth motion in their neck. We need to then work on these other elements to do this. So we'll spend some time with that interplay, but that's where this ilano-occipital joint, when we're looking at cervigenic headaches, becomes very, very important. In later modules, we'll talk about some of the trigeminal influence that occurs between this area, because this upper craniovertebral region is densely innervated, the highest number of muscle spindle fibers in the muscles, so that these muscles can react with the speed of the eyes. And when we're looking, these muscles are very tightly round and they communicate through the trigeminal nucleus. So your jaw pain patients who get craniovertebral headaches, have this. You can even have people who have, ear and tinnitus can interrelate with some of this trigeminal influence. So you often ask those people, if you ask them, your jaw pain patient, do you have neck headaches? They often say yes. You ask these chronic craniovertebral irritation headache patients, do they have jaw pain or problems? The answer is probably also yes, that they'll report having had these problems, things going on. And we'll dive into some of those as we get into later modules. But for right now, we'll kind of keep the focus on, these joint biomechanics. I'm going to search for a cleaner file of it so I can move on. Anyone have any questions? Or what do you know, or what have you done in your experience with these upper craniovertebral joints?
Dave, I'll start with the PA assessment. I also do a little bit of side gliding and flexion and extension just to see what I get. And then I'm looking kind of qualitatively, like what does the right side feel like versus the left? And does that match up with their headache distribution?
Mm-hmm.
Like, do they have the classic ram horn distribution starting at the back and then coming up over the top, maybe ending in the front forehead or, temporal area? And if I clear them and they're a candidate, I'll usually try to manipulate. If they're okay with it, I'll manipulate that upper cervical for headache.
How do you manipulate it?
I wind them up pretty good. So I'll usually do like I use a lot of like locking techniques. I kind of learned an osteopathic technique. I'll side glide them, side bend, and then I do bring them into some extension. Now my thrust is a little bit different. I'm coming more obliquely. I'll get right on the mandible actually.
Mm-hmm.
So say their left side is jammed up. I'll manipulate from left to right. I'll push on their mandible real quick and I'll say, hey, your right ear is going to head towards the pillow. And so it's real short. I try to make it quick, and basically their head just kind of hits the pillow on the right side with that angle.
Okay. Probably, typically we don't teach manipulations. We do it 7 and 8 for this. We'll look at mobilization, but we'll go over we use some techniques that what's nice about them too is we talk about all the vertebral artery portions of it, not big windups, really easy. I'm not going to give you my clean and dirty, because again, as I've gotten a bit older with this, I've been able to do it with less force and less dramatic techniques. Your technique sounds fine. I've seen it. I know what you're talking about. But we'll go over it a bit too. So understanding these biomechanics, the better I get these biomechanics in my mind, then the less stuff I have to do to people, which is. But yeah, that's why with this is like I really like to do this. Sometimes we didn't do this to module 6, but I think it's hard to go right to the middle cervical spine without really understanding this upper influence. And I think the results of it can be very profound. So I don't want you kind of coming away with half a story, when we finish this. I'm gonna switch. Fine. All righty. And we'll chat a little bit about just okay, if you're needling, doing release techniques, we'll go over some other things. But really what we're going to think about is this joint is primarily flexion extension. There is some side bending component that we will use to kind of check the end feel in these joints. But I always like to keep that kidney bean shaped, position in my mind of how the head sits within this cradle, and it's the nodding. So when you look at your exercises for this, if you look at craniovertebral like rehabilitation, what you'll see is they're isolating upper and lower. You're doing deep neck flexor activation. You're really looking at nodding in your yes exercises, which is craniovertebral motion. So whenever I do this, I always think, okay, this is my occiput on C1. If I want to go C1 on C2, which is my no pattern. So we're doing rehabilitation. We'll look at those in quadruped in different positions. Of very simple things to do is at early 30 degrees of rotation is my no pattern for C1, C2, making sure I can do those cleanly and rehab them. But whenever I think of upper cervical or at the C1, C2, if I forget, I just think of nodding yes is my pattern there for movement. It is here. That's what I want to be able to do. Right. No pattern is going to get down into C1, C2, which is coming up next. Now, this will look at some biomechanics. We are in the course. We will go over this again, but I just want to kind of get a sense. We start playing with patients of this. We think of occiput on C1. We were talking flexion. Basically a flexion extension joint. We'll talk about basically, like occipital condyles. When I do flexion, they roll forward. It's going to be basically they're going to kind of do this motion, but it's also the posterior glide. If you can think about that as that occiput rolls forward, there's a posterior glide which we're checking. And again, for doing the protrusion test and kind of coming back in, that's where we're inducing it. Let's talk about roughly about 14 degrees in literature, flexion and extension motion at this joint. And you'll see varying things. I think I've seen it as high as 17, I think I've seen it low as 12. Again, in here I included kind of my notes. I've sent these to leave an email. Here is the video that should be online available to you. I have it linked in the manual, and I'm also making I made the section of the book out for this too for it all. We'll have this in there as we go through it. And we'll go through the two techniques that we can use to look at occiput on C1. And then I'll be open to kind of looking at how you guys look at it as well. Because I think I like the way I do it, but it's just because I've been doing it a long period of time. So we'll be open to kind of looking at different ways we look at it. But as we do, I want to have our minds thinking about, I have the joint glide that's going on. I'm lengthening basically suboccipital muscles, semispinalis capitis will kind of get in our mind that as I do this motion, what am I lengthening that may be hypertonic? How am I moving the joint in these positions? And then playing between the two things. Because sometimes it's going to be myofascial hypertonicity. Other times it's going to be articular restriction. Kind of keeping our mind open that we need to understand the joint biomechanics because I'm hoping for a joint because that's anytime it's quick and easy. Muscle work can take a little bit more finesse and technique. Then you need a lot more rehab. But there, and in my example I give in here, you'll see in the videos, it's that head basically, it spins like a ball on C1. We're going to go over that learning tip. And again, in here too, in these slides, you'll see they'll have different degrees of motion that are in when they talk about axial rotation of occiput on C1. Don't worry about that so much. We're not going to spend a fair bit. We're going to use the rotation motion but it's not a glide that we're generally going to treat. Not going to be treating the ability to laterally glide or rotate. You'll be able to treat those joints with flexion, extension, and traction. Okay. So as we talked about earlier about things I do have to memorize these things. No, you do not have to memorize these things. But in your mind, I want you to think, there are some numbers in that one thing I saw in this component that explain this. And you can always come back to it as a later reference. And again, as I said, it's good to see both sides of it. And in there, I tried to always not present just stuff that supports what I'm going to teach you or what we're going to talk about. It's always good to see that there's varying opinions and where the truth lies maybe in the middle. Again, you look at different ones like from Bogduct, which is a great reference, flexion, rotation, and he's called it rotation, a bit of flexion. I think flexion's probably wrong in there. Rotation is non-physiological. So probably flexion, rotation and lateral side bending or lateral flexion are non-physiological motions. No muscle which causes that to happen. The joint is being pulled by different vectors, and it's a conjunct rotation. And that's an idea that cannot be produced by a specific muscle if we're looking at rotation or lateral flexion. Punjabi came up with approximately 7 degree rotation at the again, probably not worth, trying to assess in heavy detail and thinking about the rotation, but just to get a sense that that motion exists. And again, this is stuff that describes the technique from an old slide. I'm going to skip over a bit and go to AA joint. Anything anybody wants to tell me that they know that they think is cool about the OA joint or occiput C1, they'd like to share. I am open to thoughts, things you found, or cool things you do. Only Chan and Kevin are cool in this group. I find that incredibly hard to believe after having met all of you. These guys would be the coolest guys in the group.
I'll say, Dave, what I'm not comfortable with is the acute MVA, just making sure we're safe to even move that area, like with your sharp pursers and tests like that. To make sure that we're safe to proceed type deal. I don't see a lot of MVAs, but when they come in, I'm pretty cautious with that stuff.
The hotter they are, then the more cautious I am.
I think you're still okay to do like your suboccipital release, and like that's what I'm doing a lot with them, and like soft tissue through the neck, upper trap, mobilizing like just like PA mobs grade 1 and 2 down into the thoracic, because that's gonna still make a huge difference. So you don't have to be doing any thrust or even a grade 3, but getting those muscles to calm down and like guard and remember that like they're no longer in an accident and they can start to calm down, and just retraining that without doing anything that would be scary if you're not comfortable with it.
Absolutely. That's a perfect answer. And
I agree with that, but I also have a case right now that he was in an MVA in May and has had like constant headaches and migraines and like is dizzy and all that stuff. So he's like really screaming like VBI issues. So I'm also being like super careful with that patient, like not doing a whole lot just before, because I want to get like full clearance. But I didn't even think about like working on a thoracic area, which wouldn't cause any issues with his neck usually.
Yeah. And with him, that's where this upper craniovertebral assessment would be so helpful, because by now I'd want to get a sense of what's the motion state of occipital in C1. Likely, does he have a rotary dysfunction C2 or C1, C2, or he could have something jammed up at C2, C3 that's driving some of the headache. It's not very uncommon to see that they get kind of like a traumatic arthritis at the C2, C3, and you get that joint cleared and it moves better. So that idea that Ariel was even talking about of just, okay, you can move through the muscles and move through the range of motions. And I'm thinking about, okay, here's the motion that occurs at this joint. And I want this person to reproduce the motion at the joint, even if I'm not comfortable manipulating it or moving the joint through it myself. So by understanding the joint biomechanics and knowing that, okay, my nod, it's craniovertebral flexion. I want to work on the posterior glide. I want pure rotation motion, which is up in this upper region, is occiput or C1 on C2. I want to move into C2, C3. So being able to assess these, but I think with Ariel's very well, is understanding the biomechanics of these joints It allows you to gently move through and see, okay, I know I have a restriction here at C3, C4, which may be driving some of this, but I'm not comfortable with their acuity to manipulate it. So how can I create mobility at this segment, with movement, exercise, muscle release, or jerky mobilization that's less likely to create maybe irritated traumatic arthritis. But we'll talk about this patient in May. Actually, one of the cases that I have kind of written up for this is this exact patient, what it may be. We'll talk about how to sort through like VBI versus craniovertebral headache.
And you can reach out to me if you want, and I can go on like a long tangent about this, but a lot of times people aren't getting like diagnosed with that concussion. And so if they're
Yeah.
like, if you're looking at it and you're like, these are coupled together, but it's not getting better, they're likely like have that concussion and they weren't diagnosed with it. So using their pain as a guide, their dizziness as a guide with all their treatment. But yeah, feel free to reach out to me if you want any help with that after like they've been cleared. But if it's going on for a while, nothing has changed, or it's like staying at the same, they're probably just doing too much in the background and not allowing for like their brain to heal, basically.
Area, I've struggled writing the course manual for this, pulling in and out concussion material because we generally haven't had it in there. But once we started doing craniovertebral assessments, all this, I'm like, oh boy, it's like if you really understood like how you can tie this into, yeah, we're looking for VBI manipulation, but this is literally also the assessment for concussion, or a good bit of it, and how we tie that in. So I may reach out to you ahead of time to chat about this because, I'm always torn with it because I'm going to give you the maximum amount of value. And if I presented it only as, okay, you're thinking of cranial nerve testing and some of these other tests as, okay, VBI, not VBI, then, we're really kind of missing that bigger picture that a good clinical assessment like this is literally what you're also going to use, like what Ariel was talking about, looking at being able to assess eye tracking, vestibular system to see, is there a sensory integration problem that's doing it? That's what Ariel was alluding to, is that this person, it may be a bit of overload. These individuals have a hard time, at that point, they have focal vision and peripheral vision, and they have a hard time interpreting the peripheral vision information. They can only use focal vision. So the environment is very concerning to them, and brain can't quite process it. So it overloads them. It's not a lot of time in sports to get into it, but I want to get into it a bit because I think it's incredibly valuable, just like Ariel just talked about. So feel free. I'm going to give you some time there. We'll be able to go back and forth on this, and I'd welcome kind of your input on it because I think your approach is kind of where I am, Ariel.
I wouldn't say a pro, but I treat a lot of like motor vehicle and concussion just like with my athletic training background and things. So
Yeah. So I think we're gonna try and get out and try not to get too far off track with this, but I think it's just super valuable as a rehab component to be able to look at this as we get into this cervical assessment to think, okay, yeah, where I can tell you that this is gonna come back, and by the end of this, we won't have done like, oh, here's the 3 hours on concussion, but it'll be like you have this big complete concussion way to evaluate people. And the same assessment is very valuable in the older patient population who has balance disorder. It'll cross over into balance and vestibular integration as we build on. But understand these joints, their role in dizziness, and sometimes being low hanging fruit it's kind of an important detail because there's so much value in being able to mobilize in this area, to manipulate it, but then also to properly rehab it and assess it. So we'll go over alar ligament, tetraral membrane, and those tests as well early on, probably Saturday morning. I'm thinking they're rolled in Saturday morning, and we'll look at the upper craniovertebral like stability assessment. Well, when we get to it, and some of this stuff is rare, and if I think they're really hot, I don't do it. But many times I want to know. I want to know what the motion state is because if I think they have a torn alar ligament, I want to know it. I may give him a headache that day. Oh, but I want to know. C1 on C2 motion. It's kind of a weird thing when I think of C1 and C2. And let me see if I can find that. Go blow past the joint. Yeah, I did. Let me blow it up. Bam. Let me blow it up too much. All right. Is that bigger for everybody? Good. If you look at this, we see that the dens is in the anterior joint, and C1 spins on C2. We won't go into the ligaments. We're just going to look at the biomechanics as if there were no ligaments here at the moment. C1 is a spinning joint. And we look at the condyles, and you can't really see them well here, but we'll pull it up on an anatomy app in classes app. C1 rotates or pivots around the dens when I go to the right. When I turn to the right, the occipital condyle on the left goes anterior, the one on the right goes posterior. Does that make sense? I'm pivoting around a fixed point. If I rotate to my right, then my right shoulder goes forward, my left shoulder goes forward, my right shoulder goes back. My C1 on the left goes anterior, my C1 on the right goes posterior. Now, these joints are unique, and you don't often see it in X-rays and anatomy apps, in that they describe the articular surface as the articular surface in the cartilage. What it does is it actually makes us operate like the bottom half of C1 is convex, and the top half of C2 is convex. So what you have is you have two convex surfaces that are sitting on each other, two half balls that are resting on each other. So when I turn to my right, and that occipital condyle on the left, it's going to glide down the anterior slope of C2. And conversely, on the right side, with the right condyle going posteriorly, it's going to glide down the back slope of C1 to create this motion, because I have two convex surfaces kind of sitting on each other as they do this. So it's much different than when we look at other facet joint biomechanics as this pivot happens. Now, as you have two balls that are sitting on the highest peak of each side and they glide down the other condyles, there's a bit of, you can almost palpate it, maybe able to palpate it and feel it. There's a bit of, you'll see this, it kind of glides downward because it's descending. And part of that mechanics is thought to create some slack on the alar ligaments as they come off the den. So they'll slacken a bit as we go into rotation, so they don't tension quite as fast. I look to my right, and I think on my right, I know I have my right C1 gliding anterior on C2. I have my left C1 gliding anterior on C2. I'm having left and right issues today. And then I have my right side going posterior. So I'm getting this motion when I do this. And I have about 38, 42 degrees of pure motion at this joint. Imagine you're all familiar with the flexion rotation test, right? Flex the neck up all the way, lock out the lower cervical joints, and then you assess rotation. And you look for a restriction. So good test. It's good screening. I consider it more of a screening test. And the reason is that find that restriction, I don't necessarily know if it's the ability of the right C1 to glide posteriorly, or is it the ability of the left C1 to go anteriorly when I'm restricted in right rotation? Conversely, I think we often pick up that if my C2, C3, and I'm driving in there, is contributing to this motion, then I could be getting some noise from C2, C3, which also is going to, as I get that rotation, is going to wind. So if my right C2, C3 is stuck in flexion, it will restrict my right rotation. So I think the flexion rotation test is good. It's good screening. You pick up this tightness, but it doesn't necessarily tell you the side that is restricted. And I want to confirm that it is in fact C1 on C2 and not C2 on C3 tight vector. That's happening as I do that rotation. And again, I will do these tests. I picked them up from some of the work from Trevelyan and Gwendolyn Jaw. I will do a fair amount in quadruped of my base package, me working on rotation in quadruped, because I can work on endurance of semispinalis and the multifidi in quadruped, because the weight of the head and gravity tends to down ramp tone of upper trap and splenius capitis, some of the other muscles which are overactive. So I can work on mobility of this joint, but I don't have compression of the head into the joint. So it plays with vectors of gravity. And then I will isolate out upper craniovertebral rotation with my no pattern into lower cervical, upper thoracic rotation, going all the way and trying to initiate that motion from my lower cervical spine. So I'll use these motions in quadruped as a bit of a release technique. First cue is going to be to tuck my chin into my chest, and then I'll put an eye target. So they only come back to neutral. When these individuals have these headaches, these neck problems, I don't want them trying to look straight ahead and go into craniovertebral and cervical extension, bringing the eyes back to neutral. We do this. And I'm going to try and make a exercise handout book at the back end of the manual. We may not have time to go over, but at least it'll be a nice resource that we can kind of take a look at and go over time. So these joints we think about as being my no patterns and my yes patterns. And working exercises, whether it's in sitting in a neutral position from a lumbosacral standpoint. So my head is now, centered on my shoulders, and my ears are over top of my shoulder, is the desired position to do these from. So I'm not in craniovertebral, extension, and work these patterns. They come into play with these exercises. Suboccipital wise, we're talking here is common you're going to get to is going to your inferior and superior oblique muscles, which is going to create this motion here. They're uniquely designed to do it. They're the headache muscles. I want to work on smooth timing because one of the things you'll see in these individuals, let's say we get in there and, hey, these joints aren't stuck. Got a lot of muscle hypertonicity up in this area. If I can bring them into with my lumbar lordosis and correcting from my lumbar spine and my thoracic spine, which are big dictators of these joint positions. You can't understand these joints and what they have to do unless we understand like what we did in the lumbar spine in the first module, and then also the upper thoracic influence on these joints. It's the upper thoracic spine is the biggest influence on these joints. So I need to be here in that craniovertebral flexion, and then I need to initiate that motion pattern. And again, I'm not a huge chin tuck guy. I do deep neck flexor endurance training because most of the time I think chin tuck is just taking somebody from an undesirable position to a position that they're not going to probably do at a long basis anyway. I'm a craniovertebral, see me still, I'm a craniovertebral flexion or deep or chin resistance. I want my lumbar spine to do this and to come to this position here. Because this is all lumbar spine. This is lumbar lordosis. Thoracic kyphosis is what takes me into craniovertebral extension and need to kind of can't address these joints really without really appreciating where we are in the lumbar spine and the influence is coming from below. We rehab them. Again, occiput C1, C1, C2, or C2, C3, and mid-cervical. Well, it's more than C1, C2 rotation with questions about motion at C1, C2. Again, by the nature of this joint, I will honestly say I do manipulate this joint with a traction technique, rotary technique, but I really found that because of the design of this joint, many times a good, clean biomechanical setup and assessment with a little bit of light traction at the end will help clean this joint up pretty nicely, looking at rotation. So though there are times where I do manipulate it and it's super handy and I need to know how to do it, again, by having good biomechanics set up, it'll be you're gonna get very nice results. And my computer just reset. Again, an interesting fact on this too is that, again, one, there's a lot of weight bearing because there's a fair amount of weight bearing that goes through the AA joints because the dens can't bear weight. So the weight of the cranium is coming through this. That's why when you think about this, talk about fractures, if you kind of have compression coming through the head, it's common things you'll see different fractures associated with whether it's the ends or you compress C1 in between, you get these burst fractures because you have all the weight bearing going through the AA joints and the weight bearing joints. Also, they talk about meniscoids, which fill the space that's created. So you think about it, if I have one concave joint on top of another concave joint, I have two balls. So on the front and back of that ball, where I have this little bit of space, like in many facet joints, we have meniscoids, these little folds of tissue which fill this space in there. So many times, again, one of the subluxation models is that we get impingement of these meniscoids. I think many times these are these really acute, painful ones that you see where, I just turned this one way and I came back and I got this sharp pain and I couldn't kind of rotate back out of it. One of the models is from Bogduck was to talk about that, are we impinging this meniscoid and pinching it? As that person, you may do traction to, or you may mobilize the joint, and then it frees it up. The meniscoid is able to glide back out of space, you can pinch off it, and the range of motion cleans up. So one of the biomechanical models of restriction you may see here is that meniscoid can get entrapped during the glide. It doesn't get pulled out of the way. Bogdan talks about that when he talks about facet joints in clinical anatomy of the same thing occurring in the lumbar facet joints. And in here, again, in my notes here, we'll talk a little bit about just those facet joints and the shape of them. And also, we'll get into the slope. There's longer slopes, I believe, on the anterior side than the posterior side. Again, they'll talk about relative flexion extension of these joints being 10 to 11 degrees. I think it's relatively nominal. It's not a glide that we're generally going to be treating. We're going to treat them where means of rotation, where here, I believe this was for Jack, coming in at, at 39. So I've seen anywhere from 38 to 42 measured at somewhere in that ballpark. Going to be where we're going to be with these joints. And again, we talked about craniovertebral influence of these joints, sternocleidomastoid. I think there was a patient here just a little bit ago with a hypertonic sternocleidomastoid, from a car accident. I think she was 2 weeks prior. Ratchety movement from it. So I saw the classic, she doesn't have smooth movement, which I need to rehab the smooth movement, get that back, need to down ramp the tone. But she's in craniovertebral, let's say it's her left one. So she's in craniovertebral, right one, yeah. So it's craniovertebral right rotation with left sternocleidomastoid hypertonicity. And when I look at C1, C2, I look at her head, she's rotated to the right. So that right facet joint of C1 is anterior, the left one is posterior, because she's being held there by a hypertonic, probably sternocleidomastoid, probably just from the anterior strain that occurred in the accident. So with that, we're going to have changes in suboccipital muscle tone. So she could have craniovertebral headaches coming from there. She had actually complained of tinnitus in that left ear. It could be ramp up from trigeminal influence. We'll get into that in 6. It could be from the sternocleidomastoid. I need to follow up with her, not my patient, to see if when we treated the sternocleidomastoid, that clean it up. So I found that C1, C2 was moving fine. The glides were there. She's being held there from this myofascial vector coming in. If she's like that for 2 months, then we're probably going to have more headaches. We're probably going to have some muscle fatigue from the abnormal alignment. All right, Jen, take care. Yeah, we're pretty close here. Any questions, any new revelations, anything we disagree with, or anything you just like to add?
When you manipulate these joints, Dave, are they pretty specific or are they a little bit more, you might be getting like other segments?
I'll try and be as specific as I can. And sometimes you're going to get other segments because you're going to have forces that leak into the other segments. I think here you can isolate a little bit better to some degree. So, the amplitude and force you need here can be a whole lot less than, say, what we're losing in a lumbar spine. So I try to be as specific as possible, but every now and then you're going to manipulate C1 on C2, and you're going to hear C2 on C3 go. But it's something I try to avoid. But if C2 and C3 is stuck, then hopefully I pick it clear. So yeah, it'll be specific because think about it this way. Anytime we assess a joint glide, like if we're looking at the ability of C1 to glide anterior on C2, my glide assessment is my mobilization position, or to some degree, my manipulation position. So when we assess it, it's, we used to always teach it where it's like assessment and then treatment. I like to think of it all as kind of like one. Like once I understand how this joint glides, I can get on that joint and that, okay, it's not going anterior. Can I do a jerky mobilization to make, the left C1 go anterior on C2 and improve right rotation? So you'll learn to kind of the treatment. So that's where you can be specific with this as we look at the joint glide. So I think the rotations you can get pretty specific on. This is such a unique joint. As we get into the lower spine, then you're going to get forces, and you'll get lower vectors. There's ways of locking out as we get into the lower cervical biomechanics, locking out the lower joints to be able to protect them, to isolate your force to the joint that you're on. And again, we're going to use mostly osteopathic techniques. We're not going to be using large rotation techniques. Rotation is the motion that predominantly, if you're looking at vertebral artery occlusion and you're testing it, those are the positions you are in. We will not be close to them. So we won't be doing any really rotational high-speed techniques. It's kind of nice to know that the technique you have will be, as far as it goes, is pretty safe. So it's always good to kind of talk about, the safety that's involved and understand the safety and be able to recognize it when it's there, but also understand the techniques we're picking aren't the most cavalier techniques, because we're going to really kind of keep the vertebral artery somewhat neutral as we do most of these. Right, you have these slides. These slides are from an old presentation and was kind of made around the videos. So I put in some of the comments. I was kind of scrolling down through here. Never didn't cover alar ligaments, but all these things we're going to cover either, in one of these Zoom sessions or so I'll get another thing here, or we'll get it in during the course. So what I may do here is I may leave this one. If I'm doing next week, I will either do lower cervical biomechanics, because this took a little longer than I thought, and we can go forward from there. This is basically the second section of safety and things what we're doing. So I'm trying to kind of flow through the information, given the background, in the same way we would flow through the course. So we're going to do safety first, get into biomechanics, then biomechanical assessment, and kind of work our way through. Hope this wasn't too boring for everybody. I know biomechanics sometimes is a very dry subject to do online. So if it is, just give me feedback on what can make it more interesting.